This podcast is for educational purposes only. The information presented is general in nature and is not medical advice, diagnosis, or treatment. Watching this video does not create a doctor-patient relationship with the hosts. Always consult a qualified healthcare professional regarding your individual condition before beginning any treatment or exercise program. If you are experiencing a medical emergency, seek immediate medical care. What's up, everybody? Welcome back to the Two Bros and Some Joints podcast, where we talk about the different kinds of aches and pains patients have, what options for them may exist, and we break down common myths and just chat about our own personal experiences in private practice. With us is Dr. Nick Hunt, rehab chiropractor from Jacksonville, Florida, in private practice now for over 4 years at RTA Rehab Chiropractic, and I'm Dr. Austin Ehmke, rehab chiro from Omaha, Nebraska, in private practice now for 4 years as well over at Body Kinetics Rehab Sport and Spine. Dr. Nick and I, we graduated together from Palmer Chiropractic in Daytona Beach, Florida, with the mission of elevating the chiropractic field through an evidence-based, patient-first approach to musculoskeletal injuries. Throughout these episodes, our job is simple. Keep you guys better understanding every episode, your body and your options regarding your aches and pains. So, Nick, today we have something that you are really, really good at, and it is not necessarily always my cup of tea, but I know that I can always learn a thing or two from you, and it is rotator cuff injuries and the shoulder. Let's just dive in right away. The most common thing that we usually hear, and we talked about this before this episode today, was like the most common thing our patients hear, which is, oh, my shoulders hurt for a while. Nick, I went and got an MRI, and my doctor said it's torn. What do? I gotta have surgery, right? It's torn. Take it from there, man. What do you tell your patients? What do you talk to them about? What's the conversation like in your guys' office?
The first thing I say is I want to look at them and ask them, did they actually explain the MRI? Yeah, I mean, I can't tell you how many people I've actually looked at and worked with because, like you said, the shoulder is a personal favorite of mine. It is something that I've struggled with so many times for so many years on my own stuff and working through different injuries and how I got those injuries and how to get back to it and everything. I've basically had to start from scratch in my lifting career several times due to these types of injuries. Um, and never once gone for that MRI to confirm, like, oh, yeah, we probably tore something. It bruised over. I'm not super worried about it. If it gets to a certain point, maybe I'll think about it. But it's because the experiences that we've had with some of those people, just like you said, they come in, the doc told me it was torn. It's the rotator cuff. But they don't actually explain to them anything about what that means. What type of tear, how much of it is torn? Is it a full thickness tear? Is it a fray? Is there a bone spur that's pushing into it? That can be all sorts of different things with this. And the first thing that I like to point out to people is that they didn't actually get the explanation from the doctor who did the MRI. They just said, "Hey, it's your rotator cuff. There's a tear," and then they're told, "Well, we can fix this through surgery," but they don't get explained any other options. So the first thing I want to dive into about this topic is understanding the anatomy of the shoulder, so you can actually get a grasp of it.
Right.
First thing,
I mean, we talked about this earlier too. Is like an MRI describes tissue structure, but a patient cares about function, right? Like that's all they care
oh,
about.
exactly.
So if we can understand the tissue structure, we can actually help understand the actual MRI a lot better. That way the patient can go, oh, okay, this is actually how this is affecting my function. Therefore, I do need a surgery. Or wait, this is the thing that's hurt. The shoulder's insanely redundant. I don't actually need surgery because the injury's been there for 12 years and it just started bothering me because I changed XYZ and I got into this class and I have bad technique or my load management's terrible. There's so much nuance to it. So let's talk about the shoulder then. Like let's go through the actual anatomy because it's a really complex structure. Ball and socket joints are annoying. They're incredibly complex, but they're incredibly redundant. So let's talk about it.
So like you said, yeah, it's incredibly redundant, but it's phenomenal the way that your body's designed. So, like you said, there's a couple different ball and socket joints. Your hip is a ball and socket joint. Your shoulder is a ball and socket joint. But what makes the shoulder special is, so I've got right here, I've got two different models here that are not actual models, but they make the point very well. So we've got an ice cream scooper and a spoon.
I like both.
Okay, so the
I'm
ice
fat,
cream
so I like
scooper,
both.
they are both fantastic, and I use them daily. Um, so with your hip, We have a deep socket. We can go into it. So that provides that ball to go into the socket very deep. So we actually have structural stability out of this. So the muscles are more about movement. Why? Your glutes are a super, super strong. Your quads are super, super strong. Your hamstrings are super, super strong. So they create more movement. However, with the shoulder, it's more like the spoon. It is a very shallow bit. So that ball of your humerus sits in this and as it's very shallow. So there's not a whole lot of structural stability there. So it relies on ligaments, tendons, and muscles to wrap around to create the stability. And that is the primary job of the rotator cuff. There are four muscles: supraspinatus, infraspinatus, teres minor, and subscapularis. They all wrap from different angles, all starting on the shoulder blade back here, and attaches, wraps around your actual head of your humerus and attaches at various different points to provide that muscular stability and fine motor movements that allow you to do all of these different rotations, internal, external rotation, abduction, all of these different things that might be might sound like they're big words, but it's just how you use your arms every single day.
Yeah.
So don't get worried about the words with those, but understanding that that is a super shallow socket that requires those muscles to be functioning properly to one, hold it kind of in place so it can actually move appropriately to allow you to do those different arm movements without pain. So that's a starting point for like the functional anatomy of how these things pull, what the each muscle has a different function, whether it's for external rotation or for internal rotation, for lifting the arm, all of these different things. So when we break them down, it tells you, okay, so which muscle's injured and which which functional side effects are going to happen. Okay, so if
Right.
you tore your supraspinatus, the location of it and the function of that muscle, it runs up here underneath your trap and it goes for horizontal abduction. And
Right.
then your infraspinatus goes back into external rotation as well as with your teres minor, helps with that in different planes.
Mhm.
So knowing the function of the muscle. So if you they tell you your supraspinatus is torn because that's the
Right.
most commonly torn
Most
rotator
common.
cuff
Yeah.
muscle,
Yeah.
it tells you what movements are likely going to be most painful for you.
Right.
And then, like we had talked about before, that MRI tells you which structure it is, but they don't do a good job of explaining how is this actually going to affect you and what you're trying to get out of it, what you're trying to, how you're trying to move, what you're trying to do again, all matters on how we rebuild this and whether that tear requires surgery to get
Right.
back together. So I know that you pulled a lot of information about this first topic about this and how these tears are categorized and what does that mean. So let's
Yeah.
dive into that.
Yeah, that's in understanding just the basic anatomy of it too. That's something like we always take, especially any level of clinician, whether they're a chiro, they're a PT, they're an AT, they're an OT, they're a MD, DO, surgeon, etc. We kind of take these things for granted. A lot of times we forget that a lot of patients don't necessarily understand their anatomy to begin with. So just even taking up like a blank sheet of paper and drawing it out for them and helping them understand, but then also helping them understand like how redundant the shoulder is in the first place. A lot of people underscore the deltoid muscle for some reason. It always boggles my mind. They're like, oh, well, I don't know about this. It's like, I have a hard time getting into this horizontal abduction. It's like, you can still do it. It's funny, isn't it?
Mhm.
Like, you can still feel the contractile tissue. Well, okay, so is it completely necessary? Not always. We've had MRIs come through our office where patients didn't even know that they had one of the bicep femoris heads from their actual hamstring torn. It was no longer connected. And they're just roaming around. They're like, oh yeah, I tweaked my hamstring like, I don't know, back in '96, and it just never. It's always felt a little tweaky, but I'm fine. It's like it's not even attached. Like
It's
that's
not even there anymore.
wild. So
Something I want to highlight right there, real quick. Kind of circle back just a sec. You said something there I want to really highlight. So um, talking about the deltoid.
mhm,
Okay,
mhm.
there was a study done where they put a nerve block in for the deltoid
Yeah.
because what they were testing, what has been fundamentally taught in PT school and chiropractic school, medical schools, I'm sure, is that the supraspinatus muscle, again, the most torn one, is responsible for the first 15 degrees
Oh, is this
of
when they proved it wrong?
abduction. They
Yeah.
proved that one wrong.
Yeah.
So what it is, they put a nerve they put a nerve block on the deltoid, and you will maintain strength through full range of motion 70% without any function from the deltoid whatsoever. So it also tells you that these rotator cuffs are more responsible than people think as well. People discount on having a deltoid problem because it covers the same gap, and the rotator cuff is more susceptible to injury because it's smaller. Smaller muscles tend to injure a little bit more because they can't hold the capacity.
Yeah.
And so, but when they put a nerve block to it, they maintained 70% strength in the same range of motion with no issues. It tells
Yeah.
you like, okay,
It's
how much this stuff
redundant.
is capable of. But there's so many checks and balances. This when one goes wrong, there are three others that can do the same job. But that's also how we get some of the compensatory problems that come into this. How
Right.
we get over upper trap overactivation. We kind of walk around with this rolled forward position. Our trap's always super super tight because it's trying to do the job and pick up the slack. So there's other ways that this stuff plays
Yeah.
into the shoulder as
And
well.
and that's why like I usually joke with a lot of my patients is that like the science keeps evolving, we keep learning new things. Just because we're wrong today doesn't mean that we're not going to be 100% right tomorrow and we're going to correct it. We may be wrong today and then we're going to be wrong again tomorrow, and that's okay. That's the cool part is so long as we're willing to actually learn and accept these things, that's the biggest thing. What I see oftentimes is these larger ultimate truths like that is like because I know that we're going to talk about it later, is like subacromial decompressions or arthroscopic subacromial decompressions is like we literally used to do these routinely. I would get patients when I was working for one of the medical centers near here, an outpatient rehab. I was working for them, and we would get these, and these patients literally were no different. Even directly after surgery, even 5 weeks after surgery, even 10 months after surgery was no different. I was like, why are they doing these surgeries? And it comes out now 10 years later after I'm done removed with that, 10 years now almost in sports medicine. And it's like, oh yeah, by the way, like we probably shouldn't be calling it like impingement anymore. By the way, we basically should stop doing that surgery. It's like, wow, okay,
Yeah,
so what I was
not only
observing
should
was
we,
right. We didn't have data to back it up at the time. So you told me let's talk about the MRI. It says it's torn, right? The first thing we were already talked about was like help this patient understand their anatomy, and we do that in our offices. We bring out the models. We either sit there and draw it. I always have a big whiteboard that I go over. The first thing that I always go between, and this is what even the data says, is what was the mechanism of injury? Was this something, and you alluded to this, was this something that just like crawled over time? I call it like a crawling pain. Like, did it steadily get worse? Or did you, I think you told me you had a skier that fell into moguls and just blew their
Mhm.
shoulder up. Those are two totally different patients.
A
And
completely different
the tissue
onset, injury
structure,
mechanism, everything.
yeah, and even under an MRI, the tissue structure will look different. You'll have
Mhm.
fatty atrophy and fatty infiltration in a chronic tear. That tells me it's been there for an incredibly long time, especially if there's large gross atrophy to the muscle. Atrophy doesn't happen in 2 weeks because, oh, well, I was picking up my grandkid. Yeah, that's not how that works. That's not how muscular atrophy works at all.
Oh,
It's
yeah.
but
Mhm.
and that's it's not the radiologist that's saying this because the radiologist reads these things. It's what is the clinician afterwards? Who is it that is talking to the patient? I don't care who is, but just be right about it. And if you have to be wrong about it to then be right later, I don't care. So let's say we have two patients, right? We have one that is the acute tear, they fell. Where do they sit? Where does the actual literature sit for these people? Because as far as I'm concerned, and as far as I've read and have consistently read, all of the literature right now for an acute tear of a rotator cuff muscle says, hey, you actually are probably going to do pretty good if you actually have a surgery. But that's in, again, a really small part of the population where they do have an acute tear. What are your thoughts around that too?
No, I absolutely agree. So with that point, the specific population that needs it, like I said to you, I had a patient that had was going down a black diamond on the ski slopes, and he hit some of those moguls, was going a little too fast, and he bailed out, landed on that shoulder, completely blew through parts of the rotator cuff, complete separation of his supraspinatus, and when you have a complete separation, meaning they used to be like this, they're not attached anymore. They're just out here. This is not good because the likelihood of these things, one contracting up and basically recoiling into it. I've got a couple experiences where people have had this kind of stuff. Um, that's not likely going to respond when you try and load that joint through the movement that that muscle controls, because there's literally nothing holding on anymore.
Right.
And surgery to reconnect them, so where we can rebuild functional capacity again, is likely necessary to just reattach those things. There are other instances where you talk about like ACLs and somehow they migrate their way back and can reattach, which is,
The cross bracing
I'll always
protocol,
say it,
yeah.
the 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 body is amazing. You learn stuff every single
Oh
day, and
yeah.
it's absolutely amazing at
We're
what
gonna have
it
to
does.
talk about that.
But then there's some things that are just like, maybe we need to put this thing back together, um, with a couple stitches, and then start going back to them so you can
Yeah.
actually load it, because it doesn't do you any good if you try and lift your shoulder and the muscles are pulling on nothing.
Right. And that's where, the surgeons that I've worked with and I continue to work with, they're amazing. They're solid at this. And the ones that I work with are insanely good at identifying, okay, this is probably a good candidate. And it's based, again, not on the tissue structure, but it's based on what does the patient want? What's the function? Like, is this going to ultimately affect their function, or is there some sort of redundancy in place that's going to allow this patient to continue to operate at full capacity? I've had some of them send them to me and say, hey, we're not actually going to repair this. There is a full thickness tear. It's completely retracted. We're just leaving it though. Like, there's so much fatty infiltration. There's so much atrophy to this. It's probably been there for a decade to two decades now. We're probably just going to leave this. And that's in those chronic cases, not acute cases, what Nick's talking about. So that's where they just leave it. In the acute cases, I mean, all of the research, all of it, several articles, randomized control trials, systematic reviews, meta-analyses, they all talk about it. It's like, yeah, okay, go ahead. It's probably in your best interest. But again, that's such a small percentage of patients. Who we usually see, though, are the patients that come to us. They're coming to us because they've gone to their PT, nothing's working. They've gone to their local chiro, nothing's working. They had an injection, that's not working. They went back to their ortho, they got the MRI and they got an x-ray, and they're like, oh, there's some arthritis. Oh, and we see this like tear that's in there too. We'll just go ahead and stitch that back together and we'll be good to go. And it's like, whoa, 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 whoa. Explain to me, like, again, you're great at identifying the structure, but if that's your patients, what are you telling your patients? What are you talking about and telling them? It's like, hey, this is like, here's our choices. Because we hear that all the time is now let's shift gears from the acute side, right, all the way over to the chronic pain side. This is the patient who has had 10 years of shoulder pain, or maybe in the last 4 years it's just crept up on them. It's that crawling, nagging pain that keeps getting worse. What do you tell them?
So that person, right there is me. Exactly. Like, so I could give my actual personal experience on this. I have had rotator cuff and shoulder issues since I was playing football in high school. A couple strains that started this stuff out. You have a bad strain, you don't rehab it because you don't know any better when you're that high school athlete, and they just say keep pushing, go to the
You're
next thing.
you're a
You'll be
genius.
better by next week.
When you're
Be
16, you're a
better by next
genius. You
week.
know everything, right?
Oh, super genius, super genius, as my dad likes to say.
Yeah.
And so that is me. And what happens with these is you get that big spike. Okay. And then we start riding down, you start feeling better, you reintroduce some things, you do good for a while. And then as you're working out more, you do some other thing that's kind of more demanding onto it. We're okay. We start feeling not so great. And then we have another incident. Boom, we spike it up again. And then it kind of weighs down. So this is like our pain level here. So as we spike it, without doing the right things for it, it never really goes all the way back down. And then you're riding at this level. It's no more pain than my usual. Well, normal is no pain, so this is not normal, but your usual pain is at a 3 or 4 out of 10.
Mhm.
And then you spike it again, and then you have another injury that sets you back, and another one that sets you back because you never got the functionality back. You never learned how to use those muscles better after the fact to create more stability and get you back to a natural state. And so that's the thing that's gotten me, and why I'm so diehard about the shoulder and why I love it so much is because I got the personal experience that has stopped me in my tracks, basically started me at zero, and I had to build back up. You and I love weightlifting. We do all these type of workouts. We like to push ourselves. And I have literally had to take my upper body days down to zero multiple times throughout my journey for this stuff to rebuild it back up, and then to realize I missed a piece of the puzzle, because all this stuff is a big giant puzzle piece, and like make sure we get all these pieces to fit together where they're supposed to. And if we're missing one, We still got a gap.
Yeah.
And then we're gonna find that gap. The farther we push, um, the more demanding the exercise is,
Yeah.
the more strenuous it is, the more stability that's necessary, the more weight you're pushing, the faster you're moving it.
Mhm.
All this stuff will find those gaps. And that's the kind of stuff that really gets to you because you're like, I've been doing really well for like, 2 years, haven't had any issues. And it's like, well, now I got this new issue. It's like that's actually the same issue that's been coming up over and over again.
Mhm.
And you keep dismissing it and you're not doing the right things for it. So that's kind of how this stuff like shows up, like you said, crawls right back up
Yeah.
into it. And then at some point we get to a point where we you have to do something different for it and say, what I've done in the past has not gotten it, and this time might be it. This
Yeah.
time might be the time I got to go get surgery, and that's the conversation I've had with so many people. It's like I've done this a couple times, and I'm just afraid that this might be the time that I actually have to go get surgery. I've
Right.
had that run through my head before.
and
Um,
that and that's where you need to level with patients, and that's where like I you and I meet a lot of our patients at that position where a lot of times we're their last stop before they go have a surgery. And that's why I personally, and I know you do, we work so closely with a lot of surgeons, is I have great relationships with several of the orthopedic surgeons here in this area, and they're phenomenal at what they do. But a lot of times I'm the last stop before they go there, because usually they've gone and seen the ortho and they've come back, and I'll get a text message, and it's like, hey, this person's probably gonna come see you, XYZ. Like, do you wanna have a conversation with this person? Like they're sending them to you. It's like, okay, fine, sure. Like, hey, be aware, I'm sending somebody your way. Just look out for them. And then like 10 minutes later, I get a call. I'm like, that was quick. Like, I wonder what they said.
that's fast.
Yeah, and I'm like, oh, okay. Like they told you, like, hey, there's probably one last thing you can try. And a lot of times, what we see though is the ability of these people to recover. I mean, we were looking at like the one that I go back to is in 2024, which was like the Moon Shoulder Group, where they talked about like 10-year outcomes, where most patients in general improved long term. The majority of people who went through a thorough, stable, programmed rehab within typically the first 6 to 12 weeks, that's when they turned the page and said, fine, I'll have surgery. So if you've been at this for a really long time, longer than that, there's usually some sort of puzzle piece that you're missing. And where that comes in is if you were successful in rehab or you had some pain reduction, there may be something else that's not going right for you. What that right thing is it may be, hey, you've had a shoulder injury. You may need to change your form. Like, has anybody even talked to you remotely about load management, programming, or periodization training? Has anyone talked to you about that? No. Okay, well, why? Why not? Like, oh, hey, I've got Jeff here, my 54-year-old avid CrossFitter. Nobody wanted to talk to him about potentially changing grip stances, anything like that. No. Like, okay,
Oh,
well, we know, like, I'll use a good example, right? Is like shoulders who have a labral tear or rotator cuff tear. In this example, we're talking about, the wider you get, usually the shittier it feels. And so bring it in more narrow. It's like, did you have a conversation about that? No. Okay, well, then why'd you tell him to just like grossly stop overhead pressing? Like in one session, I can take a patient, put them into a slightly more narrowed grip, change their grip slightly, and it's like, oh, I can overhead press. It's like, yeah, you can. You just needed to change a
mhm.
few things. Now, right now, you can barely push the bar up because you have avoided doing an overhead press for 2 months, but we can get back there. Like, is that what you
Oh,
see often?
absolutely.
Is there's like those
I
little
see it.
puzzle pieces missing?
I see it so much. And you can break this stuff down on the performance level. So, you take, again, we talk about this all the time. We're going to sound like a broken record. It boils down to what you're trying to do as the outcome. Are you a, competitive power lifter where your goal is to push as much weight as possible? Your hand grip is going to be wider out. You want to minimize the distance that you actually have to press it so you can push more weight. If you're a bodybuilder looking for pec development, you're going to go narrower grip. So the outcome depends, the change that you're going to make depends on the
Yeah,
outcome that you're looking after.
yeah,
Same thing with shoulder injuries and your anatomy. Um, so between like you and me, I've got really long arms. So my bench press, I have actually moved it pretty, fairly close in compared to what theoretically I should
mhm,
because of shoulder injuries. And I've changed my
yeah,
form. That changes how far elbows flare out. If we're going to step back, we're going to raise out to a T. This is probably one of the most likely areas where we're going to get injured under heavy load because we're in that T. We don't have stability. We lose a couple different outside of rotator cuff stability factors. Lats aren't able to engage to provide stability. We have a really big pull on the pec open this way, but it also compromises shoulder stability back in here. We kind of jam up some of the joints and how they're moving, and then we tuck that in. The closer those hands come in, the more elbow tuck also has to come into this, which is
Yeah.
going to provide a more stable bit because we look at the length tension relationship of the rotator cuff. And so we want it not to be super shortened back here and not super long, tucked in here, trying to bench press or try to overhead press like this gets really awkward really fast.
Yeah.
So finding that different point and playing with it, often day one, we can get them to be in significantly less pain just by changing form factors
Yeah.
without doing any other building work and saying, this is how you're going to do these now. Let's not overload this. It's going to be awkward. You're changing it from what you're used to, but what you're used to hurt you
Yeah.
or got us in this position. So we
Yeah.
got to change something. Here's what we're going to do while we're working through this. And then we start to build the other factors of it because it's what you and I, one of those hills that we die on is like, we're not going to take you and take away this exercise that you like doing. We're not going to take that away. We're going to find a way for you to do this while we do these things so that you don't stall out in every aspect. So you can keep moving, keep getting better, keep getting stronger, and feel less pain while we're doing it.
I like to say that you're not, it's not off limits forever. It's off limits right now.
Yeah.
That specific way that you want to do this that chronically causes pain, as of right now, we're just going to go put it around some red tape. Just the way that it's working right now, it doesn't want to move that way. Let's find, it's like, oh, hey, there's a different arm slot that I can go in for. And I've worked this with a lot of like baseball athletes. Is like, hey, can you change your arm slot just a little bit? And it's like, oh yeah, my elbow feels better or my shoulder feels better. It's like, okay, well, it took me 3 minutes to have a discussion with the patient about it. It's like,
literally.
And it's like, wow, okay, well, it feels weird. It's like, okay, is it optimal? No. Did they maybe decrease like spin speed or they can't throw as hard or XYZ? It's like, well, yeah, it's like, but they can play. That's what they cared about.
But
They wanted to play. They can play
they
now.
can play. They might not be at 110%.
Is it?
But yeah, like you said, not
Yeah.
necessarily optimal for, okay, well, their goal again was to, to, throw 95 mile an hour.
Right.
Okay, maybe you're throwing 89 right now, but it doesn't hurt. And
Well,
maybe
and
if you follow this through and practice this way, you'll get that up there again with that same speed
yeah.
and it won't hurt.
And it's
You
not off
change a
limits
little bit of
forever.
fundamentals.
Yeah, it's not off
Yeah.
limits forever. A lot of times, a lot of injuries, especially sports injuries, a slight tangent is like will occur due to volume. That's usually why they happen, especially in like any sort of like non-contact, especially like an overhead sport like baseball. They occur
Like
because of volume. That's the problem, and not enough recovery. So in those patients, is like, can you change your arm slot for just a little bit? It's like, oh yeah, it feels funky. It's like, okay, well, you can still play catch, you can still do these things, you can still move, you can still go lift. We changed your arm slot just a little bit. We changed you maybe your push press or something like that, also that you're working on, but I know that the immediate rebuttal all the time is like, oh, well, it's causing more damage. No, it's not. If you really want to associate pain with damage, since you really claim to want to say that because there's pain, there's damage being done, this person's doing these things with no pain. Therefore, by your logic, there is still more damage being done. And you and I already know as well, it's like, that's not how that works. There's not always a one-to-one. So what I guess we're coming to is like the quality of the clinician that's taking care of it, the quality of the exercise therapy, what sort of physiotherapy, what sort of rehab we're doing with the patient is what matters most. And that's even, we've seen that there's a systematic review here that I have, and I love this, was they did one, it was non-operative treatment of full thickness cuff tears. So we have a rotator cuff tear, it's torn, it's a full thickness tear. 2018 systematic review, 15% of people ultimately chose surgery. 85% improved strength. 81% improved range of motion, almost 80%, it was 78% improved pain, 84% improved functional outcomes. So these patients, of the 2010 shoulders, the average age was 64. 73% of these tears were atraumatic, so we're talking about chronic degenerative tears. There's no skiing and falling off a mogul. These came in, they were crawlers. They were the creepers, the crawlers of shoulder pain. Only 15% of them chose surgery.
Yeah.
That's the only percentage that was necessary to have surgery. Like, are you kidding me? So why are we always pushing it? And I understand if you go to see a plumber, the plumber is going to recommend plumbing, but we need to do a better job of explaining to our patients necessarily like, hey, you have more choices. And it turns out if you follow a structured rehab program that is suited towards you, that is focused not on the tissue structure, but it's focused on your outcomes and your functions, you probably will get better. And that's what the Moon Shoulder Group talked about. 10 years later, same thing. It was like, wow, okay. It's like, oh,
Mm.
great. You did it in short term. Now prove it in the long term. Well, there's my proof long term now. I don't know what you
There's our
want me to
proof. There's our
provide.
fingerprints long term.
I don't know what more you want me to say about this anymore. Is like, just because there's
Oh,
a full
next
thickness
you're
tear
gonna need a
means nothing.
25-year.
I know. Oh, God, that's so funny. I just had a conversation with a patient about that this morning. It was just like, just wait 5 years. The science will change. I'll guarantee you. Wait another
Like
5
every time.
years. The science will change. And a lot of times it gets worse in one direction or better in the other. And it's like, no, we probably should stop doing that.
And
Like,
then they sit there and think, well, we were expecting it to say this, and then it showed this.
oh,
So
those are my favorites.
there you
Is the
go.
no
Those are my favorite too.
the no hypothesis switch? Yeah, those
Mhm.
are my favorite. It's like,
It's
oh,
like,
yeah.
turns out that this surgery, just like what we mentioned earlier with the arthroscopic subacromial decompression surgery, they did that for so long, and then like it turns out like, oh well, turns out we probably shouldn't be doing this anymore because
I,
one of the studies that I found literally compares it to doing nothing at all, what they call a sham surgery,
yeah,
which it means they basically go put an incision in you and then close it up. So when you wake up, there's a little cut, and they tell you they did something, but they didn't actually do anything.
my favorites.
Had the same level of statistical significance, literally no difference than the sham investigative arthroscopy.
Right.
And it's one of those studies where they're like, yeah, we probably shouldn't be doing this anymore because it's actually not doing anything.
Right. And that's always something too, like, so that way, like, listeners understand this. There's a difference between statistical relevance, like statistical difference, and what is minimal clinical improvement differences. Those are two different things. Statistical relevance is anytime like the p-value is less than 0.05, that means that it's statistically relevant. In the statistics world, like, wow, okay, we found a difference between A and B. Like, there is some sort of difference. The problem, though, is on average, depending on what you're talking about, it ranges. And so stick with me through this. It takes anywhere between about 16, the lowest I found was about 10%, up to about 30% of change for a patient to recognize clinical differences in what has taken place, meaning their visual analog scores, their functional outcome scores, their ADLs, their actual like PROMs, which are like patient-related outcome measurements. Those have to change by that much for them to even recognize, like, wait, I am getting better. So when somebody comes and says, oh, well, there's a statistical relevance, like statistically this is better, it's like, okay, that's fine. But the patient doesn't care, and the patient doesn't care about the statistics. The patient doesn't care about 2%. The patient wants to be able to pick their granddaughter up or pick their grandson up or put the box on the shelf. That's what the patient cares about, and the patient still can't do that.
Exactly.
Like, oh, well, there's 5% better. I don't care. I still can't do that.
The thing about that too, and this I think will make a lot of sense too. Um, yeah, everybody should be taking a fish oil pill as a daily supplement. Will you ever feel the difference when you take it? You know it's good for you. You
Right.
know it's helping things on the inside. But is it enough to notice? You know it's good.
I
The
notice if
thing
I take
is
too much of it.
over time, yeah, right. Over time, it'll what happens is you take it for so long, then you realize you think, "Ah, I'm not really getting anything out of it, so you stop taking it.
Yeah.
Then you notice the difference because it was 1%, 1%, 1%. But statistically significant is like right now, can we see this difference big enough that it actually makes a difference to me? It's like, okay, well, we did the surgery and we had a 6% increase. Okay, statistically significant. Awesome.
Yeah.
What were the functional outcomes for those patients?
Yeah.
And a lot of that stuff goes undone in the studies.
Yeah, and that's really where I can always appreciate both sides. I can appreciate when we can show statistical relevance or a statistical difference. I can appreciate that. I do. But can you get it so that way, because and this is why this is important, and this is why from the research side versus the clinical side this is so important for us to connect the two, and why I can appreciate so many so many PTs, so many chiros, so many DOs, so many MDs and surgeons that will do both sides, is they can see whether that statistical difference actually has a clinical relevancy to it. Because they can see it's like, wait a sec, okay, we're doing it this way. I'm spending 10 more minutes doing this BS whatever XYZ thing, but my patients aren't actually getting any better. I think, sure, on paper it makes sense, but in practice it doesn't work like that. That's probably the easiest way to explain it, is on paper it sounds great. In
Mhm.
practice it doesn't work as intended. And that's the thing too, is because we care so much about our results with our patients. We care about our patients so deeply. We want them to get the best results they can, the fastest they can, with ambition, but not reckless ambition. If we can get a patient to start to see results faster, we get patient buy-in. That actually does affect, and we know this, it affects patient outcomes. So you can sit there all day long and preach that this is 5% better than the other thing, but unless you can get a patient to actually buy into this, unless you can get a patient to actually understand that this is clinically relevant and they actually get those little snowball wins, they have a win of a day, they have a win of the week, they have a win of the session where they notice something, unless that's happening, they really could not care less. And I mean it in the nicest way possible. They just don't care. And I wouldn't either if I was going through rehab and they're like, oh, it's 5% better than this. I'm like, I don't care. I still can't do this. I can't put the box over my
And
head still.
here's the funny thing too is, some people, especially with shoulder stuff, um, I will sneak it in, the improvement. I'll change their positioning, and I've literally done some rehab where I'll use one of the longer bands. I'll have the patient lay down, and have to pull their shoulder back to engage like scapular retraction, mid back muscles, things like that, and then go through the same thing that they're trying to do, get that external rotation back, and then so give them resistance. We're doing this, because the other things are a little bit of a distraction. They won't realize that they're doing the thing that they couldn't do.
Mhm.
They won't realize they're doing the same movement.
Yeah.
And then when we pick them back up, hey, you realize what you just did there? They're just like, no, no.
Those are my
I'm like, well,
favorites.
now do this. They're like picking up the box. They're like,
Yeah.
wait a second. And then
Yeah.
then it starts to click. It's like there's a reason behind the things that we've been doing to rebuild these things.
Yeah.
And you didn't even put them together yet. Like when we tell you why we're doing these things, but we're not trying to overload, scientifically. Okay, this is why we're gonna do external, rotation, eccentric
Yeah.
loading. We're doing this to rebuild this, and then we have to work on scapular mechanics and how we're doing this. All these things are just over their head, and they don't care
It's not necessary.
until we paint the picture of saying, now go do the thing that you weren't being able to do.
Right.
And now that you
Right.
can, then you realize what we were doing is working, but they don't care about exactly how it's getting us there. They care about getting there.
Right.
And that's something that I love to throw in on some of them. It's just like, hey, by the way, you know what you just did?
Yeah. And
It usually like has an aha moment to them.
I think that's where like we can also like wrap things up on, is like you say you are this patient, say I'm going to put the acute cases aside because we already kind of closed the book on that, and I work so well with a lot of the orthopedic surgeons here who will send me patients. They're like, hey, they're just going to come work with you afterwards, like, hey, they're a weightlifter, hey, they're a baseball player, hey, they're XYZ. It's like they already know, like, you're an athletic trainer, we want you to go back with them. Or hey, Nick is in one of the gyms here, they want to go back to this gym, okay, go work with Nick, like he's in the place you want to get back to, it makes most sense, go see him again, he's going to get you back to where you need to. We're going to put those cases aside. If you're this person where you've had a rotator cuff tear, or you've had one for a while, which is what the evidence says, is that you've had it for a while, and you get the MRI, you've had that creepy crawly pain that's gotten worse over the years. I think one of the last things to like pin everything is that your level of rehab matters. What you're doing matters. And I mean this in the nicest way, where like I'll get patients who will come to us, and this has probably happened to you, where they'll do what I call, your grandma's rehab. I love my grandmother to death. She's very capable of a lot of things. But if she is capable of doing the same things that you were doing, Nick, and Nick came to me and said, oh yeah, I did all those things and my grandma's doing the exact same things for the exact same problem, I have a massive damn issue with that, because Nick's goals and
Yes.
my grandmother's goals are entirely different. That is not moving the
Yes.
needle in the right direction. And so I think that that's probably what matters the most, is your level of rehab, is what is your goal, and is that clinician focused on your level of rehab? I'm sure that you've seen this, but how do you explain that to patients? Like if somebody comes and asks you, it's like, well, why should I do this different thing? They said you're really aggressive with XYZ, and that you're gonna put these scary weights in my hands, and they told me to stop lifting over my head forever because that's bad for my shoulder because it destroys it. How do you approach that with a patient that's been led to believe these things about a different version of rehab?
So there's a time and place for everything. It may be that that person who had the acute traumatic rupture to that muscle has to start out with baby steps, and that's what I'll call them is the baby step program. You go to the PT who is a general PT. They're there to help everybody, but everything that they do is protocol driven. So they decide, okay, you were sent to us for a shoulder injury. Your primary sent you to us because you have a shoulder injury. Here's our sheet of paper on your shoulder rehab. This is a shoulder rehab protocol. Here it is. It's printed out in black and white, and it's always band pull aparts and banded external rotations. And it's the same thing for everyone,
My
I swear.
favorite.
And so when you, it's and there's nothing wrong with those exercises whatsoever. It is actually, because I still use them as a starting point for most people. But if you
Yeah.
never progress to them, you're never going to get where you want to go
I actually like
unless
using them for
your
warm up.
Austins. Oh, absolutely. Yeah,
Yeah.
I will use it'll be the first two exercises that we do to say, okay, now we're engaging these muscles. We have a little bit of mind muscle connection and you can feel it a little bit more. Now we're going to go over here where this exercise really requires stability and we're working on stability. You have to do this. Now we have a little bit of mind muscle connection because of those. And so they're a great warm up for that stuff. And like you said, your grandma, she doesn't want to, bench 300 pounds, couldn't care less. She wants to reach up
Be sick.
into her cabinet and get a cup.
That'd be
She doesn't care
sick.
about that. So if you're doing the same exercises, it's like they do have their place, yes, but if you do that same thing over and over again, it's never going to get you where to go. And so when you go through 10 sessions with a PT, they hand you off in the corner. Here's your exercises. There's your band. Go do those. I'm going to work with this guy. You're standing in the corner by yourself, just looking around, doing your band and pull parts, just flapping like a little bird, like confused. Why am I paying to come
I've
here and do this?
I've even
I
seen
learned
those
this
from
on day
Chiro
one. And
offices too, which has killed me. Is like, guys, like at least do the additional step if you don't want to participate in the rehab, and just send them to a really good PT. Like I know plenty in our
literally,
area. Like at least do that step.
yeah.
So this is a
Hmm.
dig at both those across the aisle and in our aisle. Is like if you don't know what you're doing with somebody whose functional goals are well and above what you would normally do us all a favor and send them to somebody else that is capable of it. Like that's
And
and
I want to highlight this really quick, what you just saying there. There will be chiropractors and physical therapists and whoever else that say they do rehab. You need to do your homework on these people because that's something that even these
just
studies that I've got here, um, where this was a meta-analysis that looks at several different things and it was talking about corticosteroid injections. It was talking about different surgeries and physical therapy for rotator cuff tendinopathies. And so tendinopathies being a umbrella term for something is wrong with the tendon or the muscle in the rotator cuff. So it's kind of an umbrella term. It's not super specific on talking about is there any fraying, is there any rupture, is there any of this stuff. So we have an issue with the rotator cuff muscles. And it basically just says they did a physical therapy. It doesn't specify anything that was done specifically, and that matters. So when we talk about it, that stuff is considered rehab as specialty therapeutic exercise that PTs, chiropractors, and all these people can do, and they will put it on their websites and say we do rehab, but they're doing banded pull aparts and external rotations with bands, and that's it. And this is like, well, I don't think they actually know how to get you back to that specific thing, or they're uninterested and they want to bill your insurance for an extra code for an extra $15. And so there's a lot of that to it. One of our professors back in school, Austin, said this and it stuck with me. You should not be doing rehab for an athlete that you do not know how their sport is played,
oh yeah.
as Dr. Hodges
yeah,
said.
yeah.
If you have a patient and they want to get back to playing pickleball, you better go play some pickleball because you got to know what the demands of the sport are. so that you know what you have to do to actually get them back.
Yeah.
Because if it's like, yeah, I got a shoulder issue and I'm trying to play pickleball, it's a little less aggressive than tennis, a little less of the overhand serves. So you got to understand what movements are actually necessary for them to
Mhm.
compete or play in that sport. And if you don't, you're guessing.
Yeah.
And you can guess all day long, but you're probably better off sending them somewhere else to somebody who does know that sport
Right.
rather than saying, oh, no, I can get them better because it's a shoulder issue. When you do that, you're treating the muscle rather than the movement.
Yeah.
And in order to get the results for this, you need to treat the movement, not just the muscle underneath your thumb when you're pressing down on it.
Right. I mean, that goes back to what we talked about earlier at the very, very beginning, which was you're treating tissue structures. Then you're doing no better than the MRI. You're treating tissue structure instead of the patient's function. And that's where there are levels to rehab. There are levels to surgery. There are, I mean, even within that's I've always really liked that about surgical specialties is they distinguish themselves so well into specialties where they say like, oh, I only do this. I only do revisions. I do like 25% total knee replacements and like 50% revision in complex cases, and the other 25% is like hogwash mix of other things. And it's like, wow, it's like, okay, so this person has figured out what they're really, really good at, and they really stick with it. And I see that all the time in clinicians at our level where they just have a really hard time of just picking a few things. Like when I have people who ask me specifically, they're like, okay, what do you do specifically? And I'm like, knee, shoulder, hip, and low back pain. Outside of that, you're probably better off like, can I help with it? Yes. Am I going to be the best at it? Probably not. And if you've gone to 12 other places, then I probably am the last stop before you have surgery. However, it isn't something that I'm extraordinarily good and well versed in. Or like when it comes to sports, for example, like I have almost a decade in sports medicine and athletic training background. Why do people send me their athletes? That's why, because I know what goes on in the field. I've covered sports from esports to professional bull riding to like just
Mhm.
regular I wish I could make that
Oh,
up.
yeah.
It was esports to pro bull riding, to hockey to combat sports. Like I've covered just about anything you could think of. And so just like Hodges used to say, it was like I've been there. I've been on the field. I've been on the ice. I've done those things. And I'm like, wow, okay, I understand this. That was like the first day we went to go to cover ice hockey. I'd never skated in my whole life, so I literally grabbed. I think it was like one of our defensemen. I was like, teach me how to skate. I was like, I've never skated before in my whole life. Like, teach me how to skate. And so as I better understood the mechanics, I'm like, this is how I can help these people. This is how it feels. Got it. So
Yeah,
I,
because if
I
you
could,
don't realize how you skate, you're not going to realize how much medial pressure you put on the knees every time you step out, and how you're
yes.
pushing back. You put a lot of pressure on the inside of
Oh
the knee.
yeah.
If you've not done that, you're going to be like, well, it's a knee pain. Okay,
Right.
let's see you at this.
It sure made me
And how?
understand MCL tears a lot better in hockey players. I was like, why are
Uh-huh.
you all tearing your MCLs? I'm like, oh,
Oh,
this makes a lot more sense now.
hmm
As I eat shit for the 10th time on the ice.
exactly, exactly.
But yeah, that's
Um,
I think that's a really good way to end it is just talking about, we covered a handful of things here. Was we covered MRIs, we talked about structure. If you are a patient who is in this position, always talk to your doctor about it, but understand that, there's a difference between correlation and causation. Just because an image says something does not mean it's an ultimate truth. Sure, it's there. They're just observing something. It does not mean that that is the for sure fire thing that is or is not affecting your function. Always, obviously work with your doctor, but it's okay to push back a little and question things and just ask, not to be a dick, but to be inquisitive and just better understand it. I think that's
no,
the thing we could
that's
do the
exactly right.
best.
You need to ask the question and be like, "Hey, doc, what's that mean? Like,
Yeah.
tell me like I'm 5.
Yeah.
Tell me what that means." It's
Yeah.
like, most people don't have medical training. They don't have big backgrounds in this stuff. Uh, it's okay. Ask them literally and just say like, what does this mean? What does
Yeah.
that mean? The MRI doesn't come with necessarily instructions and a little sticker that says inside your body, it says pain here,
Yeah.
pain caused from this.
Yeah.
It's like, well, it's a picture in time, and we look at all the things that are going on inside it,
Right.
but none of them sit there with a little red sticker that say pain is coming from here.
Yeah.
We look at everything, and you can have 10 different things going on because your body can you can have everything. I forget which law that is, but there can be as many problems going on that may or may not be associated with any symptoms. Um,
Oh, that was LaRose. LaRose
And
used to talk about that. The
yeah,
cardiologist, he would talk about that is the
Dr.
patient.
Blazer or something like
Yeah,
that. Yeah.
the patient's allowed to have however many damn things wrong with them as they would like. However, it is not
Mhm.
always meaning that is the source of pain. That was that
Yes.
was that
It
was
doesn't mean,
LaRose. Yeah.
yep. Yes. And it's so, so, so true. They can have all these different things wrong. And again, it just brings me to highlight another study that they did for like low back pain and disc degeneration and disc herniations. You can pull 10 people, every 10 people you pull off the street without pain, without any symptoms, well, 8 of them will have disc herniations.
Oh yeah.
They got no symptoms, but their MRI is going to show positive, and that surgeon's going to say, "Oh, well, you need surgery. I can fix this, but you don't have any issues. Why would you go voluntarily have that surgery to say, let's fix these things that aren't causing me a problem?"
Yeah. And that's where you always need to correlate it with your clinical findings. That's why
Always.
we have a picture of the tissue and the structure. Let's talk about the function. Like, is it or is it not truly the thing affecting the function right here? Is it the patient's load management? Is it their volume? Is it their form? Is it their technique? Did an injury happen in the past and they just have been so butt-headed about the fact that they won't change the way that they're doing things that they actually do need to change the way they're doing things? And it could be a 10-minute session that suddenly now they feel better bench pressing. I think that's probably the easiest way to wrap it up, is like a lot of it is we go back to your comment. It depends. There's so much that goes on with this. Just because something is torn, just because there is something on an imaging, on finding, it doesn't mean that that's the end all be all for it. And I think that's probably the easiest way we could sign off on this, is like, obviously, talk to your doctor about it. Talk and be inquisitive, ask those questions, but push back a little bit and just get a good explanation. Better understand your body so that way you can make better choices with what you're doing and how you're doing it, and whether that is something that is just a picture in time or if it's something that's actually affecting your function. There's a massive difference between those two things. And if your doctor has a hard time explaining those two things, then they may not necessarily be related. They might not be, and that's okay. But then that's a time and place where that doctor then refers them to somebody like us, or refers it to some people like our friends down the street from us. Those are the best times where we can finally start to work together and understand, okay, here's a limitation to what my imaging can tell me. So I think we nailed everything today. Do you think we did? Think we got everything? We
I think
went
we
from the
did.
MRI, full thickness tear, the levels of rehab.
I think we covered a lot of things. We can always literally talk for like 10 hours on these things. So
I
we
know.
got to cut it
I
off
know.
somewhere, and
I know.
there'll be
I
more
like it
info on
here.
another episode. So
For sure, for sure. Well, all right. Well, we're signing off here. Thank you guys for listening to the Two Bros and Some Joints podcast. We're talking about rotator cuffs and all of the good things that come with it. We will be back next week, and next week's topic is going to be fun. Is should chiropractors be doing rehab? This one is going to light some fires underneath of asses, and I am A-okay with that, because
here for it.
we like rehab, and you can't tell us otherwise. You will take it away from Nick and I's dying hands as soon as we're dead.
Yep.
All right,
Yep.
guys. We'll see you guys next week.